So welcome everyone to the OTAC clinical case webinar. Tonight's topic is medicinal and non-medical cannabis use in OAT settings. And tonight presenting will be Professor Nick Lintzeris, who is Senior Staff Specialist at Drug and Alcohol Services, Southeast Sydney Local Health District, as well as a Conjoint Professor of Addiction Medicine at the University of Sydney. We will also have Dr. Sharon Reed joining us to monitor the chat. She's a GP working in addiction medicine at Royal Prince Alfred Hospital, as well as a senior lecturer in the specialty of addiction medicine in the Faculty of Medicine and Health at the University of Sydney. Before we begin, I'd like to acknowledge the traditional custodians of the country on which we meet and recognize their continuing connection to land, waters, and culture. I'd also like to promote the OTAC scholarships. We're in round 3. This scholarship is open to unaccredited general practitioners and nurse practitioners who work in private settings, especially in regional and rural areas. The round 3 of applications will close on the 29th of May, which is in about 2 weeks. And the registrations for tonight. So we have about 95 people registered from all over New South Wales, as well as South Australia, Victoria, Queensland, and even New Zealand. And we have a strong showing from Northern Sydney Local Health District and Southeast Sydney Local Health District. And also for the specialties, we have a lot of general practitioners leading with pharmacists as well, but we have a strong showing from all roles. So thank you very much to everyone for joining. And just about a little bit about the clinical case webinars. These are monthly webinars that we hold on Tuesday at 6. They're typically case-based. And for those who attend in person or live, we will be sending a certificate that you can use to claim CPD points. And also the OTAC webinar will be recorded and made available online at the OTAC website. So just some general housekeeping before we begin. I'd like to ask everyone to keep themselves on mute unless you're speaking. And if you have questions, feel free to type them in the chat, and Sharon will also be monitoring the chat. They are recorded. And also, if you have conflict of interest, please exit out of the webinar. I'd like to hand it over to Professor Nick Lintzeris. Thank you, Nick. And I'll unshare my screen.
Thank you, Jessica, and thank you to the OTAC organisers for inviting me to present this evening. Let me just get my slides set up. So can people just give me a nod if you can see? Yeah.
Yes.
Okay,
Yep.
great. So thank you. I'm going to be presenting around the issue of medicinal cannabis and cannabis-related issues in opiate dependence treatment. So it's me, and also I'm going to be using some of the slides coming from Dr. Leila Parvaresh's current PhD work about some of the survey work that we've been doing as well. I just want to acknowledge the lands that we're on, traditional owners of the land, and elders past, present, emerging. I don't have any major conflicts of interest relevant to today. I've had some medicinal cannabis-related research funding, but not really about what we're going to be talking about. I'm also on the board of the Pennington Institute and the Australian Medicinal Cannabis Association. All right, so what I'm going to do is just a bit of background around cannabis use disorder, medicinal cannabis, just to set the scene. Going to be talking about more specifically around issues that relate to people in opiate dependence treatment. And then we've got a couple of cases. Hopefully I should get through all the presentation in the first 20 minutes or so. So I'm going to rush through things. If there's any questions, please put them in the chat. And if they're burning questions, points of clarification, then Sharon will reach out to me and tell and interrupt. Otherwise, we can have the questions at the end. Okay. So just a bit of background information. Recently, there was a National Household Drug Survey was recently completed. And this gives us our first real estimate of trying to get a sense of how many people in Australia are using medicinal cannabis, because it's a population catchment, epidemiological population catchment survey. So it does try to survey people according to population. And so from there, you can try to extrapolate into broader population levels. So the household drug survey is actually asking about the year 2022. And when we look at the estimated number of people using cannabis in the last year, in 2022, you can see there that these are people aged 14 and over. And it's about 22,000, so 22 million people were sort of in the when you extrapolate out. So it's excluding people under age 14. You can see there that 19 million Australians did not admit to using any cannabis in the 12-month period. However, 2.6 million Australians did say they used some cannabis. Of those, 1.9 million was for non-medical reasons, and 700,000 had some medical reason. The slide on the side to the right gives you a breakdown of the proportions that use it never for medical. So that's 8.8% of the population said they use cannabis at least once in the year for non-medical reasons. 1% only for medical, and 2% sometimes for medical, sometimes for non-medical. So you can see that it's about a quarter or so, a quarter of all people that say that they're using cannabis identified that there's some medical reason as to why they were using the cannabis. They then went and asked, where do you get your cannabis from? And so you can see there the graphs on the left. 92% of all Australians said that they accessed illicit cannabis. So this was not prescribed by a doctor. 5.4% said they only get it from prescribed from a doctor, and 2.1% a bit of both. When you hone in though on the people that said that they use it for medical reasons, you can see there that there's still the vast majority, 70%, are accessing illicit cannabis, and only about 30% said they had a prescription from a doctor. The panel on the right gives you an indication of the frequency of cannabis use. And this is really interesting because when you look at the non-medical cannabis users, you can see the vast majority really only dabbled with cannabis, used it once or twice in the year, and another 20% used maybe once every few months. When you look at the proportions using once a week or more, or every day amongst the non-medical users, it's around 30%. However, look what happens when people are using it for medical reasons, where much higher proportions are using it either several times a week or every day. So about half of the people using it for medical reasons report using cannabis on a daily basis. So there's quite a bit of a difference there in the patterns and profiles of use according to medical versus non-medical use. It's possible to estimate that up to about 250,000 of Australians aged 14 and over were prescribed medical cannabis in 2022. Now, to put that in context, this was a medication that was illegal before 2016. So within 5 to 6 years, we've ended up having 250,000 Australians using these medications. Now, I just want to contrast that with some data from opiate agonist treatment in Australia. We've recently published some data looking at public sector opioid treatment populations, and about 40% of patients reported using cannabis in the last month. This slide, though, actually comes from Layla's PhD work, a survey done amongst 6 local health districts, the opiate dependence treatment clinicians. So we went and asked clinicians, tell us about what you think your clients are doing. They estimated that about over half of their clients had used cannabis in the last month, and just under half had not used. And when you look at the breakdown, again, we're seeing there that the majority, that this is what the clinicians thought was happening. We haven't surveyed the clients yet. That's going to happen later. But when you ask the clinicians, they estimate that about 1/4 of all opioid dependence treatment clients are using cannabis most days of the week, if not daily, and about 20% using it at least weekly, and under 10% using it less than once a week. So you can see there that there's greater similarity in the use of cannabis amongst our opiate treatment populations it looks more like a medical cannabis population when we're talking about the frequency of use, largely daily or regular users, several times a week, if not daily. I'll come back to that, to those issues in a moment. But a bit of context. What do we mean by medicinal cannabis in Australia? Now, some of you may well be prescribers or pharmacists who are already involved in medicinal cannabis, so you know about this stuff. But for those of you who aren't, we've had the ability in Australia since 2016, either as a special access scheme or authorised prescriber, to prescribe a range of products. There are now currently over 800 products that we can prescribe. But these are all unregistered medications. So that means that they've not been approved by the TGA for any indication. Rather, they're just listed, and we as doctors, if we're going to prescribe them, then it is under these unregistered conditions, SASB or authorised prescriber. There's some
Hi there.
there you go.
Sorry,
I've unmuted. Yeah.
Okay, yeah. So there was someone else that didn't have their mute on. So just double check everybody that you do have your mute on, because we heard some conversation in the background. Thank you.
Any doctor can prescribe. You do not need any training or credentialing. Any pharmacist can dispense. Likewise, no training or credentialing required. In terms of the medications we can prescribe, they're categorized into 5 categories. At one end of the spectrum, it's CBD only. At the other end of the spectrum is THC only. And then we've got some in between where there's a combination. And you'll look and see in the next slide what those categories are. We also have a range of formulations. We can prescribe herb or flower. This is essentially cannabis plant. And this is when we prescribe this, we prescribe it for vaporization. This is using a dry herb vaporizer. It's different to, say, e-cigarettes. E-cigarettes has all those chemicals in it that we're not sure about the safety of them. With a dry herb vaporizer, what you're essentially doing is just vaporizing the cannabis plant. What vaporizing does is it heats the plant matter to a temperature at which the cannabinoids, which are oils, turn into vapor and they get inhaled. But you don't actually end up burning the cannabis. So it's associated with much fewer sort of toxic chemicals than if you were, say, smoking cannabis in a joint or a bong. So it's a much safer route of administration. We also have a range of oral liquids, oral capsules. Recently, in the last year or so, or 2 years, we've seen the emergence of a range of sort of liquid products with either THC or CBD, which are much more like an e-cigarette. So these are liquid products, and you need special vaporizers to use them. If you're applying in New South Wales and you go through the TGA portal for your SASB, it's actually, they've made it very simple that you can also apply for a state Schedule 8 permit. That's for New South Wales Health, if you believe the patient is drug dependent. So if a patient is, you're familiar with New South Wales legislation, if a patient is drug dependent and you want to prescribe an S8 drug, such as THC or opioids or amphetamines, or the S8 drugs, you need a permit to prescribe that drug, even if it's for another indication, even if you're not treating drug dependence. So if you wanted to treat chronic pain with THC and the patient, say, was on a methadone program, you would have to apply for an S8 permit. THC is an S8, and so it is recorded in most SafeScript systems across Australia. There are those sort of dispensaries that don't sort of behave like a pharmacy. They're sort of more an integrated model, and some of those don't seem to be using SafeScript. Also, remember, SafeScript is a state-based piece of software. So when I look into my SafeScript, I can see what doctors and pharmacies have prescribed and dispensed in New South Wales. However, if a patient has had medication dispensed in another state, that won't show up in the New South Wales SafeScript. And what we're seeing increasingly in Australia is the emergence of a range of telehealth clinics. Queensland has the vast majority of them, followed by Victoria. So Queensland and Victoria are the biggest prescribing states of medicinal cannabis, even though the patients don't necessarily come from there. So they're meeting a national kind of need there. So if the medication was dispensed in New South Wales, it will appear on the safe script. If it wasn't, it probably won't. To give you a sense of the cost of medicinal cannabis, THC herb, that should read $10 to $15 a gram. So that's quite comparable to illicit cannabis. So illicit cannabis, depends how you buy it, if you buy it in bulk or you buy it, in small grams or in big ounces. But often you're looking in that $10 to $15 a gram, so up to $20 a gram. So the cost of medicinal cannabis is actually very competitive compared to illicit cannabis. We have the product CBD oil. This is far more expensive. It's around 10 cents a milligram. So if you're using therapeutic doses, high doses, like say 400 milligrams a day, that ends up being about $40 a day. So you can see that's quite sort of prohibitive for a lot of patients. Okay, so I'm just trying to get to the next slide. Sometimes happens, I've noticed. There we go. All right. So what are these two medications, THC and CBD? THC is the cannabinoid that most of us will associate with the effects of cannabis. So it causes most of the things that we think of when people use cannabis: the intoxication, the euphoria, the sedation, the appetite, tachycardia. For some patients, it can also cause anxiety, and in a very small proportion associated with psychosis. THC itself has very mild analgesic properties. It's not a strong analgesic. It does get used for chronic pain, but its main role there is probably sort of some of the, it's more some of the coping with pain rather than severity of pain issues, because it itself is not it's not as potent an analgesic as, say, as an opioid if you're doing a cold pressor test, that kind of thing. For non-tolerant individuals, when we're prescribing oral doses, then it's usually in the range of 10 to 20 milligrams a day. For people that have got pharmacological tolerance, so regular cannabis users, then often much higher doses are required in that 50 to 100 milligram range. The other main cannabinoid is cannabidiol, or CBD. This has got a range of different kinds of properties. It itself has anticonvulsant, antipsychotic, anxiolytic, and anti-inflammatory properties. It itself is not intoxicating, and there's no addiction to it. So there's no withdrawal when you stop CBD. A lot of the early animal and clinical research suggests that it may reduce cravings in people with a range of substance use disorders, alcohol, opioids, cannabis, and so forth. It can cause drug-drug interactions. So cannabidiol itself is a potent inhibitor of a range of cytochrome P450 enzymes. And as you all know, these are the enzymes that are most implicated in the metabolism of methadone. So CBD can inhibit the metabolism of methadone. And if you think about, if you're inhibiting the metabolism, that means you are increasing the plasma levels of methadone. So CBD can result in an increase in methadone plasma levels, which can result in some of the clinical features of methadone toxicity. And there's been at least one case report of an methadone overdose after a patient started CBD. The doses that we use of CBD are highly variable. Most clinical trials are looking at doses of 400 milligrams a day or more. Because in Australia, the CBD is not subsidised and quite expensive, often we find a lot of patients are using much lower doses, say 50 milligrams or 100 milligrams a day, because that's all they can afford. We don't really know whether or not those doses have got much therapeutic benefit or not. Okay, so what's being prescribed? So when you apply for a SASB or if you're an authorised prescriber, you have to notify the TGA of the category of medication that you're intending to prescribe. And you can see there are 5 categories, as I said before. THC dominant, category 5. Only THC is category 5. THC dominant is 60 to 97% THC. The remainder is CBD. Category 3 is about equal parts. CBD dominant, category 2, and then CBD only, category 1. And you can see in Australia, the vast majority of prescriptions are for the THC dominant, THC only product, followed by CBD only. On the right, you will see the types of formulations that are being prescribed. Oral liquid for both THC and CBD is by far the most common formulation, but we're seeing marked increases in the prescribing of herb products, and that's been increasing in recent years. You can see the range of other the range of other things that are available, but largely it's oral liquid herb. We're seeing an increase in the number of inhaler products, and the other stuff's probably very small fry. What conditions are we treating with medicinal cannabis across Australia? The vast majority of patients, the indication is chronic pain, followed by a range of mental health conditions, most notably anxiety, depression, and PTSD. Then we have a range of sleep conditions, and these seem to be increasing in recent years. And then we've got a range of other things there. You can see much smaller proportions for neurological, GI, cancer, and so forth. For me, what's really interesting, when you look at the main indications that have been prescribed, mental health, pain, and sleep. Now, I think that's particularly pertinent for an opioid dependence treatment population, because we know these comorbidities are particularly prevalent in methadone and buprenorphine patients. Most studies would estimate about 30 to 60% of methadone and buprenorphine patients suffer from chronic pain, and comparable proportions suffer from mental health, and something like 20 to 40% experience sleep difficulties. So you can see these are extremely common comorbidities in our opioid dependence treatment populations. And this, going back to what opiate treatment providers think. So this, again, asking the clinicians, tell us what you think the harms and the benefits of cannabis use in your methadone buprenorphine patients. On the right, you can see the harms. And interestingly, the staff identified that the most common harms were addiction, money issues, increased use of tobacco, withdrawal. So sort of issues that relate to the use of cannabis rather than other harms. You can see the other harms, some sleep problems, memory, cognition, problems with work, legal relationship, and so forth. Now, anyone that's worked in sort of substance use disorder, we're familiar with harms. We spend most of our time thinking about harms of the drugs that our patients use. What we don't often do, though, is think about the benefits of the drugs that our patients use. And when we asked our clinicians working in methadone buprenorphine, so what do you think some of the benefits may be for patients using cannabis? And the top 3 reasons were sleep, mental health, and pain. So it's difficult not to think that maybe what's going on here is a lot of self-medication of comorbid conditions, as well as issues of dependence and addiction to cannabis. Now, of course, those are not necessarily unrelated. We saw before that patients using their medical cannabis, largely for pain, mental health, and sleep, tend to do so on a daily basis, which is going to increase your likelihood of withdrawal, dependence, and financial problems. So you can see these sort of are going hand in hand. And I think this challenges us to reconsider what is going on with cannabis use in opiate dependence populations. Okay. When we ask the clinicians, what proportion of clients do you think have got a problem with their cannabis use? It was around 40%. We asked the clinicians, what proportion of clients have said to you that they've got a problem? And it goes down to 15%. What proportion of clients wanted to do something about their cannabis, it's even lower. And what proportion sought any treatment is down to 10%. So we as clinicians think almost half of our clients have got a problem. However, it's much smaller interest, much lower rates of interest amongst our clients in doing something about it. When we ask the staff, what kinds of treatments or attempts at treatment have your clients thought about? Self-directed attempts at stopping, counselling. And then what surprised us was medical cannabis treatment at 13%. And we're thinking, really? Like, is that what our staff think? I mean, we're going to ask the clients to see if that's true or not. But, you know, almost 1 in 6 patients prescribed prescribed methadone or buprenorphine, our staff thought were accessing medicinal cannabis. So, sorry, I'm going to move those on. So let's look at the role of medicinal cannabis in opiate dependence populations. Now, I want to talk about...
Nick, could I just interrupt before you progress? Whether it's appropriate to ask now, a question in the chat. Rosie was wondering, when the slide going back a couple, there was something about the evidence supporting the use for particular indications.
Yes. So,
so Rosie was wondering whether you'd be able to cover the nature of the evidence and that supports these indications.
Sure. Yep.
Is it appropriate to talk now, or you want to save it for?
So, no, let's talk about it now, because I'm not going to revisit it. So, I mean, that would take me about a 1-day sort of workshop to go through all of those in detail. But snapshots, very quickly. Chronic pain, most common sort of reason why doctors are prescribing this. There is a lot of debate around the world about the nature of the evidence base for cannabis treating chronic pain. When bodies such as the TGA, the National Academy of Science, so when independent bodies like that go and review the evidence, their summary of the evidence is that there is clear evidence for a mild or moderate benefit for treating chronic pain. Modest evidence, so not strong evidence. And more importantly, the evidence suggests it's a mild effect. So the evidence is there, but it's not going to blow anyone away. It's not kind of like it's not that impressive. Probably about as impressive when you look at the numbers need to treat, about as impressive as our evidence for antidepressants in the treatment of chronic pain. Similar numbers needed to treat. Now, many of the pain faculties in Australia, many of the senior pain groups, their assessment of the evidence is somewhat different. They look at the very same meta-analyses and say, nah, we don't think that the evidence is robust enough to recommend using it for chronic pain. So what that basically means is the meta-analyses and systematic reviews are telling us one thing. The senior pain doctors in Australia are saying something else. When you look at what patients say, when you ask patients around, is the cannabis working for your pain? Overwhelmingly strong support. Overwhelmingly, the majority of patients who continue to use medicinal cannabis for pain will say this has a major impact on my pain. Not for everyone, but for the vast majority. That's pain. Mental health, is fair to say that the evidence for THC, for anxiety, depression, and PTSD is sparse, poor, and really cannot be recommended. That's not to say that the studies have been done and THC has been shown to not work. It's that the studies have not been done. We do not have good clinical trials. Randomized controlled trials, well conducted, properly blinded, the stuff that we look for when we're assessing evidence. So the evidence for mental health is largely absent, not negative, not positive, just absent. And then for sleep, sleep's a little bit complicated. Sleep's like a lot of medications that help you sleep, like benzos, they work really well in the short term. But THC disrupts normal sleep architecture, like most sleep medications do. They decrease your REM sleep. You get used to that. So after a period of time, you try stopping your cannabis and your sleep is a mess, a little bit like stopping benzos if you've been using them for 6 months. So most of the sleep doctors are saying, look, it can help short term, but this is not the future of sleep medicine. It's not, it's like using a benzo for long-term chronic sleep problems. Does it work? Yeah, sort of. Is it a good idea long-term? Nah, probably not. That's my 3-minute summary of the evidence of medicinal cannabis. No doubt there may be, it's hard to summarize very complicated evidence in such a short sort of window.
That's great. Thanks very much, Nick.
But let's look at the evidence. Thanks for that plug. What's the evidence of using medicinal cannabis to treat cannabis dependence? Beautiful segue. The biggest, best study ever done was led by me. Of course it was. So this is a study we published a few years ago in JAMA, and it was a randomized controlled trial comparing Sativex. Sativex is a oral mucosal spray of a THC CBD 1-to-1 product. We were using, it was flexible doses, but the patients themselves were using around 50 milligrams of THC a day, 50 milligrams of CBD a day. And it was a placebo-controlled 12 weeks of treatment, and we followed them up 12 weeks after treatment. On the left there on the panel, you can see what happened to the days used of illicit cannabis. And basically, there was less cannabis use in the nabiximols or Sativex arm than the placebo arm. And that was a significant difference. So there was significantly less illicit cannabis use in the nabiximols arm. But what was really interesting is that when we followed people 12 weeks after we stopped the medication and stopped the counselling, you can see there that people did not necessarily relapse. Over half of the people in the nabiximols arm, when we followed them up, 12 weeks after treatment stopped, said that they had not used any cannabis in the preceding month. And that was about 20% for the placebo arm. Now, this for us got us quite excited because this got us thinking, this is like a nicotine replacement model where we may be able to use medicinal cannabis. This is for people that, are motivated to stop their cannabis use, obviously. We may be able to use it for a short period of time, break those sort of behavioral addiction type behaviors, also help with the cannabis withdrawal, the taper down and so forth. And so this might be a useful model for thinking about treating cannabis dependence. And given something like a third of opioid dependence patients, probably 20 to 40%, somewhere in there, our clinicians thought it was around 30, 40%. If about a third of them meet criteria for cannabis dependence, then it does raise the issue of, well, should we be treating their cannabis dependence with medicinal cannabis? Because when you look at our other treatment approaches for cannabis dependence, we've got counselling, and that's about it. We don't have other medications. And counselling seems to work better in those people with less severe cannabis use, fewer other problems, fewer comorbidities. How do I put this? Not the kinds of patients we have in our methadone and buprenorphine programs. So if we want to think about how we're going to treat cannabis dependence, then we probably need more than just cannabis, than counselling, and hence the role of medicinal cannabis. So this has got us thinking about, I've come up with the idea of 2 models of thinking about prescribing medicinal cannabis, especially in our opioid dependence populations. The first is the idea of abstinence from all cannabis. So this is the patient that wants to stop. And I'm proposing we think of this as an NRT model, where we use the medicinal cannabis for a period of time, I'm saying 4 to 24 weeks, adjusted for each patient, where we use the medicinal cannabis, taper the doses down over a period of time, and then hopefully the patient, and then with counselling, and then looking at cessation. I would strongly recommend using an oral product. Oral products are more like a slow release. So you can see the graphs, the difference between a vaporized herb versus an oral down the bottom. Vaporized, the dotted lines is the THC and the 11-hydroxy THC. They're the active, that's the active metabolite. Carboxy THC, that's the THC-COOH. That is not active. That's inactive. That's the stuff that's in the urine that we test, in a urine test. So you can see there's a big difference in the time frame. Oral products, they have a duration of effect of around 6 to 8 hours, whereas vaporized is about 1 hour, 2 hours maximum. So if you're looking, in most areas of medicine where we're prescribing drugs, we like prescribing long-acting, not short-acting drugs. So this is one model. The other model is what I would call more the harm reduction model. Now, this is for the patient that may not necessarily want to stop all their cannabis, but certainly wants to reduce the harms of their illicit cannabis. And again, what I'd be proposing here is using a combination THC-CBD, emphasizing oral rather than vaporized. Sometimes I add a vaporized product, say at nighttime, to help the patient, say, with sleep, but wherever possible, try to move them to an oral product. Now, again, if you're going to be prescribing to patients with tolerance, you need high doses. So it's not the 10 or 20 milligrams that we use with our cannabis-naive patient population. Okay, so there's sort of the two kinds of models, a sort of an abstinence and a harm reduction model. Now, this is causing a lot of sort of consternation in many sort of circles about, well, hang on, aren't you just swapping one drug for another? Illicit cannabis for licit cannabis. Is this medicine? Are you just a drug dealer, a legal drug dealer? Now, anyone that's worked in methadone, when I started working in methadone over 30 years ago, this is the conversation we had to have all the time. Is methadone real treatment? You're just swapping one opioid for another. Fortunately, I think 30 years down the track, most people, even the most conservative medical and AOD people would at least recognize the benefits of opioid dependence treatment. And I think there's some similar parallels here, some of the harm reduction. So prescribing medicinal cannabis, we're looking at safer cannabis products where we know the composition. We can also make sure that there's sort of CBD, not just THC alone. Safer routes of administration. Getting patients using oral or vaporizer is much safer than bongs or joints. Over time, we can shift client goals. They may start using, 2-3 grams of cannabis a day. Over time, generally, we can often get these patients, down to much lower amounts of cannabis over time. It addresses most of the legal issues of prohibition, so at least it means our patients can't get arrested for having cannabis. They're still not allowed to drive on THC, but, for other things. And the other thing it does is it brings us in contact with this patient population. Tends to be younger men who, generally would never go see a doctor in their lives unless they had to. So again, it's sort of engaging these patients with a range of other health considerations. Okay, very quickly, CBD for cannabis use disorder. Does it work? Well, all the early data is promising. CBD probably dampens cannabis withdrawal. It seems to reduce cravings and may even reverse some of the cognitive and neurological deficits associated with heavy cannabis use. A pilot study was done a couple of years ago, which they showed that the effective dose probably is around 400 milligrams a day, better than placebo and better than a lower dose of 200 milligrams, and as good as 800 milligrams. That was a small pilot study, 4 weeks, wasn't powered to demonstrate, conclusively if CBD works. But what it has led to this study, which we can say has gone live today. I think the first 3 participants in this study were recruited today. It's happening across a range of places across Sydney and New South Wales and Newcastle, and even Melbourne. So if you're interested in the study, there's the sort of the flyer for it. There's an email account address, or just email me. So this is currently recruiting. Very quickly, the issue around opioid dependence and cannabis opioids. What's going on there? Anyone interested in this? There's been a wonderful review just been published by a group of Australian authors. That's the reference there, and I would commend anyone interested in this, go read the paper. It's a really nice paper, and they go through a lot of the issues quite well. What's the rationale for this cannabis opioid link? So cannabis works because it works through what we call the endocannabinoid system. We all have cannabinoid receptors, that's why the cannabis is working on us. Similar to the endogenous opioid system. Now, it turns out that there is huge overlap between the endocannabinoid and the endogenous opioid system. So the cannabinoids are involved in things such as opiate withdrawal and craving. So there is a pharmacological rationale for this. It's not just about getting people stoned. A lot of methadone and buprenorphine patients say, look, I use cannabis because I don't use heroin anymore, and I don't want to use other drugs, but I don't like being abstinent. So of all the drugs I can use, cannabis is the least harmful for me. So a lot of patients seem to be doing that. We saw the comorbidities before, the high prevalence of chronic pain, sleep, and mental health. So it may well be that there may be a role for medicinal cannabis in treating some of those common comorbidities. And I would argue that one of the things that we see when you look at methadone and buprenorphine treatment outcomes, and you look at drug use, that the drugs that people are using when they enter treatment, heroin, alcohol, benzos, stimulants, cannabis, and you look at what happens over time, the use of alcohol, heroin, cocaine, amphetamines, and benzodiazepines all reduces with time. They all sort of drop off. Cannabis use doesn't seem to change over time. It's resilient. You look at your methadone buprenorphine patients, it's the same proportion you're using cannabis 1 to 2 years after starting treatment as they were at the beginning of treatment. So this is leading some of us to think this may well be patients self-medicating for their comorbidities, not just this is a substance use disorder issue. Of course, it's really difficult to tease those out. It's really hard to say, oh no, you're just a comorbidity person versus you've got an addiction to your cannabis. And indeed, as I was saying before, maybe both are occurring. There's a lot of ink and heat and debate about, is cannabis opioid sparing? Epidemiological data suggests yes. There are no clinical trials of this. No proper clinical trials have been done looking at opioid sparing in chronic pain patients. There's a lot of observational studies or patient reports where patients with pain using opioids are prescribed medicinal cannabis, and many of them reduce their opioid use. But that's not high quality evidence. We don't have the randomized trials. One day someone might get there. So what can we say about cannabis in opiate dependence populations? Firstly, as I said before, most commonly used drug in opiate dependence treatment and doesn't change over time. What does cannabis use do upon opiate dependence treatment outcomes? So do cannabis users have better retention or worse retention in methadone bupe treatment? Answer is varies according to the study. Probably the overarching overall impact is probably associated with slightly better treatment retention, but a lot of heterogeneity in those studies, so we can't be confident about that. In terms of cannabis use effects on things like other substance use, again, lots of mixed effects in those studies. I want to remember there's, different studies report different things. And again, if we had to say anything, probably tending to be associated with less use of other opioids, but nothing clear about that. a lot of people have been interested in, is there a role of medicinal cannabis in helping patients come off their methadone or buprenorphine? So this is eventually stopping. When you go and ask patient, so some surveys of this, about 10 to 20% of patients say, yep, cannabis is what I use when I'm trying to get off my methadone or my bupe. So some people say cannabis is a really good drug to help me stop my methadone. We have no clinical trials of this. There's only been one study ever of a cannabis product, and that was a rubbish synthetic dronabinol for heroin withdrawal, and it suggested high doses are effective in dampening opiate withdrawal symptoms, but one small study. So we have to say that despite a lot of patient report, we just don't have the evidence whether or not cannabis assists in opiate withdrawal. We mentioned the issue around medicinal cannabis in treating comorbidities, and we need to, so that's something I think is going to be happening more and more. And then the issue of CBD. What can we say about CBD and opiate use? There's been some Q exposure studies suggesting high-dose CBD reduces opioid cravings in heroin-dependent patients, but these are lab studies. They're not clinical trials. Again, remember, caution around the use of CBD in methadone patients. Remember, it inhibits the cytochrome P450 system, not just 3A4, it's a range of CYP drugs, CYP enzymes, and this can result in methadone toxicity. Oh, okay. We started a little bit late, about 10 minutes late, so I'm assuming we'll go about 10 minutes over time. So sorry for anyone who may have sort of be planning to log out at 7. But I've got 2 cases. Sharon, do you want to moderate these, or do you want me just to speak to them and go for it? Okay, I'll just speak and go for it. The first case is Barry. Barry is a 59-year-old on methadone maintenance. Started in his mid-30s for heroin dependence, and he's been on it now for 14 years. He's now on 85 milligrams a day, 4 takeaways a week. Hasn't been using any other drugs in recent years, except for his cannabis, where he uses 2 to 3 grams a day. So that's a lot of cannabis. He smokes bongs pretty much first thing in the morning, gets up. Before he goes down to the chemist, he makes sure he's got his brekkie bong already loaded and uses that. He also uses tobacco, he estimated probably about 5 cigarettes a day just by packing the bongs. Doesn't smoke cigarettes otherwise. Comorbidities, he's got some anxiety, panic attacks, he's on a bit of Valium and some mirtazapine. He's got chronic osteoarthritis of both knees and he's awaiting surgery, gets pain from that. He has been put on some pregabalin, although again, there's no neuropathic pain, just he's on it though. He's had some chronic bronchitis because he was a heavy smoker over the years. He gets shortness of breath on exertion and he's on some Seretide. And based on someone using 2 or 3 grams a day, he's probably got a cannabis use disorder as well. So, some questions. What do people think? Is there a role for medicinal cannabis for this patient? What might be some of the potential benefits or harms? So again, look at I'm just going back, look at his comorbidities, anxiety, chronic pain, bronchitis, and he's using 2 to 3 grams a day and he's getting 4 takeaways of methadone. So this could be a difficult format to actually get people responding. So I'm just kind of wondering, should I just lead the discussion? Sharon, what do you want me to do?
So what we've done in the past is if you're going to ask a yes/no kind of question or so people can just quickly write in the chat their answer and then we can get a bit of an idea of their response. So is there a role? Do you want people to answer?
We could do yes/no for that one.
Yeah.
We go yes/no for a majority response and then we can talk about why that might be the case.
So could everyone in the chat please write their response to this question? Is there a role for medicinal cannabis for this patient? What are the potential benefits and harms? If you could just quickly write yes, no in the chat, that'd be great. We get a bit of an idea. So far, it's looking like a good couple of yeses. One says yes, for respiratory benefit. One says no. A probably, a maybe. I don't think there is evidence to support use for comorbidities, maybe for harm reduction re cannabis use disorder.
Yep.
Yeses, looks like mostly yeses so
There's
far.
Majority yeses, but some people that are saying, look, I'm not convinced by the evidence and I wouldn't want
Yes.
to do it. Yep.
Yep.
I think that's actually quite spot on. I mean, you saw my response. Yeah, probably. Again, our evidence base for pain, anxiety, and it's kind of yeah, it might work. And often we don't know if medical cannabis will work for a patient, say for their pain or anxiety, unless you try it and see what the patient says. Did it work or not? Clearly, the potential benefits for this person is the harm reduction role of their chronic bronchitis. He's probably using 20 or 30 bongs a day with tobacco. That's not good. So being able to move that patient over to an oral form, I think would make a lot of sense. Okay, what type of medicinal cannabis could be considered? I've already blown it by telling people we should probably prioritize an oral. But even if the patient said, no, I want to smoke it, even vaporizing and convincing him he's got to get a vaporizer would be better than oral, than what he's doing in pulling bongs. I would recommend that if he was saying, nah, I'm not keen on the oral, I would at least encourage him to be using some oral to reduce the amount of herb. And over time, once you realize the oral works, then you could actually reduce the amount of herb over time.
Nick, Wendy in the chat's asking about oral mixture.
Oral
mixture.
mixtures.
Yeah, I think, yeah.
Let me have a look.
I don't know whether it means.
That Wendy, must be a typo.
Yeah, maybe it's mix. Oh, yeah, typo mixture. I thought you might have meant tincture.
Yeah, all the same.
Yeah.
So I would definitely propose an oral product for this patient, given the respiratory issues. Given the THC CBD, now there is not much evidence about CBD alone for pain, some emerging evidence for anxiety, PTSD, but not compelling at this point in time. There is evidence that if you add CBD to THC, so the combination has got better analgesic properties than THC alone or CBD alone. So I would probably be recommending a combination THC-CBD product. CBD only is not going to satisfy Barry's 2 to 3 gram a day desire to be getting intoxicated or for those effects. So he needs probably some THC. So I would be probably recommending an oral THC-CBD formulation. And if that works over time, looking at how you can ideally over time reduce doses, as we can often do with a lot of patients.
Yeah, there's a couple of chat points in the chat about, if someone says, if I prescribe flower for vape, it seems that my patient still just uses it in bongs. And Susan says, prescribing oral doesn't mean that he'll use oral. Hope he gets script dispensed for the oral form if you also prescribe a dried herb from pharmacist experience.
Absolutely. Just because you prescribe it doesn't mean the patient fills it. Now, you can actually see what the patient filled because you can go onto your safe script if it's a THC product. But again, just because they filled the script doesn't even mean that they're taking it. As we know. Ultimately, asking the patient is potentially the most accurate information you'll get unless the patient doesn't want to disclose what they're doing.
Yeah. And Rosie just asks, is Barry having any counselling?
What do people think? Do you think Barry should be getting some counselling?
You could put some yes, no's, maybes in the chat if you like. What do you think?
Hey,
Williams,
I think
yeah.
everyone should be getting counselling, but then what we've got to start undoing is unpacking. Well, what does getting counselling mean? So if you're in a public clinic where you've got clinicians and counsellors available free of charge, then it's much easier to try to engage Barry to get some counselling around his anxiety, around his pain, around his cannabis use. All conditions would benefit from some counselling. In private practice, though, finding the psychologist or social worker that will bulk bill and that Barry is not $50 to $100 out of pocket per session can be difficult. I mean, I'd be keen to see what some of the GPs are proposing about, counselling. Yeah. So if you work in an LHD, then I think it's eminently achievable and should be encouraged.
Yeah.
But
I guess it's sometimes luck, isn't it, about where you're working and what's near you.
Yeah.
And accessible. And
certainly you can refer to an LHD for the counselling. Absolutely. Depends on, obviously, your own local. And there are a range of, so some of the PHNs do run, psychologist access with subsidised, so they get bulk billed, the patient doesn't have to pay. So there are emerging schemes and there are ways of trying to get your patient accessing counselling. And absolutely, I would strongly, strongly recommend it. Last question. If you were to prescribe, say, a oral THC CBD 1-to-1 product, do you need an S8 permit to treat Barry? And assuming you're going to go, say, with a chronic pain indication. Yes, no. Do you need to apply for a permit?
No one's responding yet.
Okay.
Some people are just stuck on an acronym BHOP. Not sure. And yes, it's coming through now. Yes,
So the important thing, again, remember, it's an S8. If all our methadone buprenorphine patients are drug dependent by the meaning of the Act, by definition. So you've got to get your S8 permit. Okay, so that's that patient. Next case. They're quickies, these cases.
Oh, so, Better Health, sorry. I'll tell you what BHOP is. Better Health Outcome Plan through GP. Yeah.
Yeah. So that will give you 6 Medicare sessions. Absolutely. The challenge is finding a psychologist that bulk bills. Because, I mean, my experience is that most psychologists are charging $50 to $100 above the Medicare fee. So they don't bulk bill. But if you've got one that bulks bill, hang on to them and don't give their name to anyone else. Otherwise, they'll get swamped and they won't take your patients. Okay, Jenny. Let's look at Jenny. Jenny's a 48-year-old woman on 65 milligrams for the past 5 years. Again, also treated for heroin dependence. She gets 6 takeaways a week. She works as a carer in an aged care facility. Her substance use, look, she uses a little bit of cannabis at night, 1 joint, 2 joints, and she can go without. She's not fussed about the cannabis, but she finds it does help her sleep. She has been on citalopram and Valium for a long time, prescribed for her anxiety, but that's stable. She doesn't misuse her benzos. No problems with that for a long period of time. She drinks every now and then, a bottle of wine, or once a fortnight, once a month. The staff, though, commented, the pharmacist contacted you saying, look, Jenny was here the other day just saying, picking up a methadone, but she said she was just not feeling herself. She's been really, really drowsy and increasingly sedated in the last couple of weeks. So at your next appointment, you review her. She says, yep, I've been drowsy most days. I've been falling asleep in the afternoons. She normally has a methadone in the morning. It's actually sort of causing problems with me at work. And look, I had a minor sort of dingle with the car. I just, I kind of just scraped the car against the garage when I was parking, you know, and again, I was just so exhausted, you know, I'm not myself. I don't know what's going on. She, no change in her substance use, not using more, not tucking into the Valium, hasn't used more cannabis, nothing's changed. She does say, though, that she's been increasingly stressed due to some family problems. You check SafeScript, nothing showing up, nothing untoward, same as it's always been. She did say, though, that she recently, though, did use one of those telehealth clinics to get a plant-based medicine, which, by the way, she started about 2 weeks ago. So, what could be the causes of her increasing sedation? Now, sorry, that's not a very good Zoom meeting question, isn't it? A differential diagnosis. There could be a range of things. Now, rightly or wrongly, working in opiate dependence treatment, one of the things we're always going to do is just think to ourselves, wow, maybe she's under-reporting her use of other drugs. And one of the things we might do there is get a urine drug test. So would you request any investigations? I should have asked people to put that in the chat, but anyway.
Yeah, I mean, some people have just wondering
yep.
whether the CBD, and I think they mean out of state, does that increase methadone levels?
Yeah. Ah, bugger. So you've already jumped to the gun, guys. Yes. So you've already gotten to the punchline, but the sequence of events would have been what's going on. One of the things, do I need to change her takeaways? Like, well, hang on. You know, she's getting 6 takeaways, but if she's sedated, but there's nothing obvious. You know, you do a urine drug screen, comes back negative. You've checked SafeScript, nothing. Sorry, my cursors are stuck and I can't get to the next one again. There's always. There we go. What does plant-based medicine mean? Exactly. This is a euphemism that increasingly is being used to get around some of the TGA restrictions. As you all know, it is illegal to advertise medicines or medications directly to consumers. That's not allowed in Australia. They do it in America, but in Australia, we can't do direct advertising. So a clinic really should not be saying, come to us for your medicinal cannabis. That's technically advertising, and there are some there's a range of services that are falling foul of the TGA. So what we're starting to see now is the emergence of this kind of euphemism, plant-based medicine. And so when you see plant-based medicine, look, it could be a naturopath, could be a Chinese herbalist, but often, increasingly, what you're seeing, that's code for come get your medical cannabis here. And then she sort of says, oh, yeah, I didn't really think about that. I didn't think about it. She did start CBD about 2 weeks ago. She thinks it's helping with her anxiety, but she wasn't 100% sure because all she's really noticed is that she's just been bombed out for the last 2 weeks. So is it helping with dealing with the family problems? Not really, because, she's not thinking clearly. So essentially, that's what was going on here. The CBD inhibits the cytochrome P450 system, slowing down the metabolism of methadone, resulting in an increase in methadone plasma levels, which is also why she was particularly reporting of feeling sedated in the afternoon, 3 to 6 hours after her methadone dose, which again is the peak methadone plasma levels. So well done, Rosie Hamilton, I think, who actually got it straight away the moment I put the case up. God damn it. Well done.
Yes,
why did it not show up in the urine? Cannabidiol is metabolized to carboxycannabidiol and will not show up in the urine test unless you specifically asked for carboxycannabidiol, and you will not find a laboratory that knows how to test for it. It's only sort of for research purposes. And the THC was there because she's been using it. The benzos were there because she's been using it, and there was nothing else. You know, all that was prescribed, or you knew she was using it. And it wasn't on safe script because CBD is a Schedule 4 medicine, and there is no, it won't show up in safe script, even if it had been prescribed by the doctor around the corner and a pharmacy around the corner. Okay. What changes would you recommend in a methadone dose? Well, I'd be picking up the phone, talking to the prescriber of the cannabidiol, letting them know, look, you know, you may or may not have asked, but the patient's on methadone and this is causing problems with the methadone. One of the things is, you know, getting a sense of, is the CBD actually working? Is it worth persisting with? Or it's kind of like, gave it a go. Doesn't, you know, if the patient's saying, look, I'm not sure, I think I want to keep using it, I definitely would be reducing her methadone dose, definitely. By how much? I would drop it probably by about 10 or 20 milligrams straight away. And then, you know, touch base with her every few days to see how she's coping with that, and also the pharmacist is reviewing on a regular basis. As for the CBD dose, again, 200 milligrams a day is sort of in that bordering on the therapeutic range, not quite. Anything less is probably homeopathic. Okay, here's some really useful resources, some good websites there about medicinal cannabis, the TGA, New South Wales Health, and the NPS. And I'll just finish here with a plug for our study. If you've got people that are interested in stopping their cannabis use, then think about this study. I must admit, though, being on methadone is an exclusion from this study because of the CBD interaction. We've got no problems if you're on buprenorphine. Buprenorphine's okay, just not methadone.